disruptive change, we often wonder just how suitable it is for our country and our homes. So at this time, I would like to request our esteemed panelists to kindly take the stage and help us understand if we are in fact future ready for this paradigm shift in patient care, and what all do we need for this innovative access and the access solution to be able to benefit patients. And as I announce each of the panelists' name, I request that they please join us by taking their seats on the stage. Please put your hands together in welcoming Mr. Sanjeev Navagal, Managing Director, Janssen India. Dr. Ratna Devi, Founder, International Alliance of Patients Organization, IAPO. Javed Zia, Country President, Novartis. Gareth Jones, Founder, Healthcare at Home. And may I also request Mr. Amit Mokim, GM South Asia, IQVIA, to kindly join us on stage to moderate this session.
Very good morning. Well, Sanjeev, thank you for setting such a wonderful stage. And I loved the cartoon because I was, before the session started, I met Sanjeev outside and I said, after your speech, we'll all feel like being like patients. But to me, it's very true and very real. So I was reading a research study that was recently done, and in the US, the actual interaction between doctors and patients has fallen by 17% over the last 3 years. A lot more people are actually either searching for their own care-related information or interacting in very different ways than physical interaction. The other thing I want to put on the table, and we've got some great experience from the UK. And I remember 5 to 6 years ago when both of you were in India, we met at the Burman family office, and one of the questions they asked is, do you think the Indian market is ready for it? And my honest answer to them was, I don't know. But I think y'all have done a fantastic job in making the market where it is, because this is a need that is truly there. We've got a great panel and some very good friends on the dais. And Javed, if I start with you, today you have a lot of global programs that run, and then you've got a completely different market in India. Where do you see on the maturity level? And when we were designing the whole patient support programs, more interaction with patients, where did you want to get to as you launched it? What was the goalpost when you set off?
I think, if you were to, we tend to, of course, there is so much of literature, and the good news is that, there's a lot of experiences and programs which have been there in the Western markets. And obviously, we can read a lot about it. But then I think, looking at each of these programs has to really be tailored to the healthcare system that is existence in the country. And I think we all agree that India is an extremely unique market with such a high proportion of self-pay. And also, I think as a nation, we have treated health as as was pointed out by Sanjeev, it's almost like a crisis situation. When things are really bad, then we decide to take all the measures that we need to. So preventative healthcare per se, is not something which is inbred into us as yet. And I think that's the kind of transformation that is really we should be, focused on. So I think just to give you a very simple from how we looked at it, I think it's really a lot to do with how the ecosystem starts to develop locally. Number two is that you cannot necessarily only do it alone. So you really need to see what kind of partners and people are coming into the market who can possibly offer you the kind of tailored service that you're looking for. But I think prior to that is more about defining the needs. And I think I'll just confess to you that even as Novartis, having operated for such a long time in the country, probably it's only 3-4 years back that this is the first time in the history of the organization that we decided to bring in a bunch of patients and, started to do the typical, sort of listening into them on their disease. And it was, of course, related to the particular product that we wanted to launch, but, just listening them, hearing them out. Exactly what were they suffering from? What were the key? And there were some stark realizations that started to come in terms of the, what the doctors were kind of thinking that the patients would require versus what the patients themselves would be selling. So the gap was, huge from that point of view. And so then, comes the whole area of, how do you sort of use those inputs to be able to sort of, tailor make these programs. And I think we are, I think we have been very lucky that we did get in touch with, Healthcare at Home at a very early stage. And we have put together a program for one of our drugs in the whole area of treating psoriasis. And it has worked out well, really well, because close to the product is now in the market for, just to give you an idea, for about roughly now, we have completed 2 years there. And almost one in every, out of 2 patients, 1 person is basically on this particular patient support program, which allows for, the drugs to be injected, right at the home of the patient in terms of convenience. But more for the convenience, the patients have talked a lot about, how their disfigurement and their how they felt about their lesions over there and having to move to a doctor and a hospital every time and things like that. So those were some of the key concerns which they had, and those could be so well taken care of. Then the second thing is you could also kind of build that on together with the whole area of delivering the drugs along with that. So a number of things that you can think of now, and then of course you can have a closed loop system whereby you're also getting the diagnostics done over there, and then passing all that information out to the doctor too. So I think just as a one-off example, it was an eye-opener for Novartis. And now I think what we have started to do is that if I think about a product launch, we always have the pre-launch phase, and you do a lot of good work over there, then you have the launch phase, etc. And these are all patient support programs, things like they're always an afterthought. It's always after you have launched the product that you start to say, okay, maybe what's the new thing to do? Can we put in something or the other? But now I think we have reached a stage whereby a product, when we are sort of already thinking in terms of the launch process, already thinking in terms of the registration process, already thinking even prior to that, the pre-launch activities, we already are thinking of how we're going to bundle the product launch together with the services that we are going to be, whatever they are, already predefined. Also, what happens from a budgetary point of view? You generally tend to, when it's an afterthought, when the product is launched already and then you start to get into these things, then it becomes very difficult also to apportion resources behind it. But if you plan for it in very early stage, then it's almost a part and parcel of the launch of the product and the service, put together. So that's where, I think we're moving to. But I think, what is important to understand is that it really needs to be customized to the needs of the Indian, setting and the product setting. And, obviously, how is it a product, is a specialized product? Is it a product which is for the mass market? Each of those things have to be taken into consideration.
Thanks, Javed. Just one more quick one to complete the thought process. You see, you made an interesting point that this whole process becomes very relevant as you're thinking through the whole launch and registration. Now, from a pharma company's perspective, the entire engine was very oriented towards how you build a lot more awareness and connect with the doctor community. But now, with this becoming more prominent, it also means how you engage with the patient community, right? Mm-hmm. And the current model of sales and marketing and the reps and everything else, how do you see that changing? Because now you've got a completely different stakeholder to deal with, right?
No, I think, it's a very, very good point, because, what I'm also trying to take into account is also the kind of innovation that is coming out now. And if you all agree with me that, now if you look at the big pharmas, the research that is going on, the kind of products that are coming out, no more it is the run-of-the-mill products. There really are products are being selected for, products which really offer a departure or a huge gap, a huge difference and upscaling from the current standard of care. So which means that, products are being brought to the market where they truly are revolutionary. That is the norm of the day. A lot of R&D products are being kind of, cut out where they are just simple incremental improvements. There are now, products where you have to no more the norm that you would kind of, show yourself to be better than a placebo or et cetera, et cetera. Those are almost gone. Now you really are looking for products when you're testing them out. The trials exactly go head-to-head trial with the standard of care products, and then you demonstrate a huge efficacy and a safety, behind that. So if you think about it from that backdrop, that's the kind of products which are coming in. So which means that you really need to upscale the whole education piece of it completely for the patient too, because the patient will not be going to the necessarily, to the doctor with the kind of information base that he would have at the, currently. So in order to be able to really maximize on your innovative portfolio that is coming through, you really need to make sure that you start to apportion a lot of money towards, I would say, not only money, but I think it's the thought process and more of the integrated, programs that you need to think in terms of how am I going to be having a social media program, how I'm going to have, I'm going to be utilizing digital to be able to communicate directly, how am I going to be using. So social media is now starting to play a very, very important role. And I think, we have seen that with some of our new launches, and although again, of course, and a lot of learnings that are coming through. And in terms of the kind of responses that, so for example, again, I'll just give you the example of the psoriatic drug, going in and hide psoriasis. This is one of the digital social media programs that we put up. And it's amazing the kind of responses that we have been getting in terms of, patients wanting to directly contact us, wanting to know which doctors they want to go to and things like that. And that also raises a lot of dilemmas, because there's a lot of learning when you are doing these things, because there's also a lot of compliance standards that we have to sort of, adhere to when we are embarking on this particular journey. So the learning, so for example, you are not going to go pick up the phone and say, hey guys, go to this particular doctor or something like that. That's not the way to go about it. So then the question comes in, and how do you then in turn link yourself up with somebody else who is a arm's length party, who can really better guide a doc who is kind of doing biologics and in his town, et cetera, and so on and so forth. So there's a lot of, the networking and the community that within that medical community that you have to sort of, you are trying to sort of connect all these dots put together. So I completely agree with you that the future with the kind of new launches and the biologics in particular, with some of the, even in the mass market brands that I see around, you really are going to need to engage with your, with the consumer directly. And yes, of course, there are rules and regulations that we all have to adhere to, but we need to find very, very creative ways to be able to communicate that messaging, which again is all about education. And I think that's where I think there is a dire need also in the Indian marketplace, whereby sort of credible, unbiased sources of information and domains are available, which the patient can access to without worrying about, is this being paid for? Is this something biased where I'm being directed towards something or the other? So that skepticism has to be curtailed so that they can really directly go and not waste their time in the internet space.
No, thank you, Javed. Gareth, if I turn to you, when we met and I said I don't know, about the feasibility, one of the reasons was compared to the UK, where you have a very well-established primary care system, the whole care continuum that Sanjeev showed on a slide. You have community hospitals, you have the whole program where care is discharged and commissioned in a more streamlined way. India is the Wild West with respect to that, right? And I won't mince words in saying that in many ways, caregivers and nurses are more glorified maids than anything else in the country, right? Now, in that context, and from the point you started off, what were the key elements of the model that you brought in from your home country, and how did you have to change it? And what's really been the journey and the experience, if I put it that way for you?
Sure. Can I just thank Sanjeev for his introduction, because you set the scene extremely well. My observation, having been here for several years now, is that you have elements of a very modern healthcare system, shiny, top-notch hospitals, very, very top-notch doctors as well. But the patient gets a very bad deal here in India, a very bad deal. So they pay a lot of money, particularly for biologics and the newest medicines coming along. They get no time with the doctors because the doctors are seeing so many patients. They go home, they have virtually no information at all. And then there's no evidence or data to support how well the patient's doing on that particular treatment, et cetera, et cetera. Now, Charles and I brought 25 years of home care experience here to India, not only from the UK. We had set up home care services in other countries, in Europe and Australia, as Vivek mentioned. The one guiding principle that has served us very well all through is to have the highest standards of clinical service delivery. So we've always been a clinical service delivery company, no matter whether we're still delivering medicines as part of the integrated packages that we provide to patients. We are a care provider. We are agnostic to the prescription decision, and that's really important. So a doctor in a rheumatology clinic, a consultant in the UK, he has now 5 or 6 biologics to choose from to treat his rheumatoid arthritis patient. As it happens, every one of those has a home care service that goes with it, because no biologic now in the UK is launched without a home care service. So we came to India, we did our market research, and we concluded that we met so many people. We met yourselves in the pharma industry, in the insurance, the doctors, and there's no doubt there's a huge requirement and need for our type of services. Home care is not for everybody at all, but it can certainly make a huge difference in terms of accessibility to treatments and products. And also, it's our focus on the patient. Every service we've ever designed has always started with the patient in the middle and built. And typically, we would, with a pharma company like Novartis, like Pfizer, like we dealt with everybody in the UK. We would get together, agree joint objectives. So this isn't one organization saying just do this, or we got together joint objectives, piloted the service, and I think 95% of the time, with a few tweaks, the service was extremely successful. Now, I'm actually passionate about proving the value of what you do. And here in India, one of the great challenges is you have very little data as to you've spent all your money on clinical trials and all the evidence showing your product is a very good one, but when it goes to the market, you have very little to show of evidence to demonstrate patient outcomes, cost effectiveness, and the like. We have drugs launched in the UK now where the NHS demand evidence of efficacy before they pay. Performance-related paying for medicines. Now that's quite scary in the pharma context, but I think the pharma industry here has because of the rapid changes going on, has a great opportunity, I think, now to look at not copying necessarily what we've done in the West, but I think certainly adopting some of the principles and building services where the patient is in the middle, and the patient has to. We have this program called the Expert Patient in the UK, where a well-informed patient who is not only educated in the disease, but is counselled in how best to take the medicine, how to be adherent, i.e. take the medicine as prescribed, and stay on that medicine as long as the doctor prescribes it. These are really important principles, and that expert patient is encouraged through the likes of home care organisations like Healthcare at Home. They are encouraged to take control over their own disease and disease management. And this is the long-term goal of everything we're trying to do together, is the patient at the moment has very little control. They don't have the knowledge or the motivation, and we're in a position to help them. And we have some wonderful case studies and stories of children who are on life-saving treatments, a weekly IV infusion. Our nurse goes to the school with that child, sets up the infusion, sits in the back of the classroom. The child misses no school at all. This is just normal behavior fantastic stories like that. And that's I know we'll be achieving stories like that here in India. What we as an organization have is absolute conviction that if you do it right first time, and those sticking to particularly the clinical, excellence, because number one, we have to prove that everything we do is safe, and it is equivalent, if not better, outcomes than hospital. Then we know the patients love being treated at home. That every time, ask the audience here where given equal resources, expertise, etc., where would you prefer to be treated, home or a hospital? Our infection rates are a tiny fraction of a hospital. So we have the evidence, and what I'm really keen on here is to provide that evidence in the Indian context.
Brad, I have two more questions for you. One is, if you look at India again, it's many markets within markets, right? You got people for whom support means get the money to buy the medicine. And some people for whom support means I need the whole hand-holding, the awareness and everything else, right? So it's a whole continuum, and you can't ignore both markets unless you say that, look, I want to be there for the urban rich, and that's what my model is, right? I think the second thing is today, and it could be same for the UK or the US as well, today the doctor as a stakeholder plays a very critical role in forming the bridge. How have you navigated on both these fronts? I mean, have you taken really a call that, look, I'll go after, and to demonstrate success of this program, I'll only take a certain pool and a segment of patients, because first I have to build the case for this program, and let me just look at the next set of patients later, right? Has that been the approach? And the second is, how have you got the institutions and the doctors on board? Because to me, the institution is literally handing over the patient to you, right? And that's always, that uncertainty that's associated from that process.
Yes, I'm very familiar with the challenges you're describing. Certainly, we don't compete with hospitals. We work with them. See, you have the situation in India where a patient pays a lot of money to go and see the best consultant they can, whatever treatment is prescribed, and then out they go, and there's nothing for them then. We can work with hospitals. We can increase doctors' reach and retention. I think there's a lot of initial skepticism from doctors. You have a very doctor-centric healthcare market here. There's no doubt about that. And that will slowly change as the consumer, the patient, becomes more, more powerful and knowledgeable. So we don't have a business unless doctors are on board with us. And I must admit, even after 5 years of working, nearly 5 years in India, it's a slow process. Early days when I came here, I spoke to a lot of oncologists who said, home oncology will never work in India. It does. We've been doing it. But these are relatively small numbers of oncologists who see that my patient comes 300 kilometers just to get an IV infusion. And we've proven, again with evidence, that it's safe to do it at home, excellent outcomes, and he continues to refer patients. But this takes time. It takes time, and that's building patient by patient and reputation, etc. I think, as you know, some of the institutions like Apollo have their own home care services. In our view and all our experience, those will always They might be very useful to Apollo, but they'll always be limited to the geography of that particular hospital. Whereas, again, we're agnostic to doctors, hospitals, anywhere in the country we can provide home care. And truly, if we, a little bit like working strategically with pharma, with joint objectives, we can do the same with hospitals, where we do have tie-ups with some of the hospital groups, where the more enlightened ones see that if we can have a seamless transition from hospital to home, but still seen as a hospital extended service, then those patients are going to come back to that hospital, aren't they, if they require further interventions or in the future. And we can provide that extension, hundreds of kilometers away if necessary. So going back to your question, I think doctors are the biggest challenge in India. The way doctors think. Now we get a lot of the younger doctors a lot of whom have worked in the West. They've often seen the benefits of the type of services that we provide, and they're more willing. I think I think we've got a long way to go yet in India, though, to really. I think, and again, working with pharma, I think we can accelerate that process, because if it's no good doctors just getting one message just from, say, home care companies like ourselves. If they're getting similar sort of messages from pharma, from insurance companies, from other players, even the government eventually, then doctors, I think, will embrace this a lot more quickly.
Yeah, I'll just add some, practical examples to exactly what you were talking about, right? Is that you have, so for example, in the same situation that I'm just giving you this particular case study on the psoriatic drug. I mean, clearly it was, you really had to make sure that you had a win-win situation dealt out and discussed with the concerned physicians. In fact, you would have wanted them that they would be the ones who would be rolling out this patient support service and it is seen as a benefit to their patient that they will be, handing over. Interesting thing is that, yes, initially they would show that resistance, but there will be some of the innovative minds who would embrace it. But then I think as people saw, and I think what is really important that we are talking about is data. If you start to bring in data to show how, for example, compliance is kind of, is so much better when a person is on the patient support program compared to when he's been coming to your clinic, and, the kind of dropouts that you are having versus when the patient is on patient compliance, and you can bring that data out and showcase it. And it's amazing. Some of these data are, even in a country like India, and sadly so, until unless, you think about it, the efficacy of a drug really is all about if he or she is not, the patient is not taking the drug, for that prescribed period, really we have done disservice to the patient. Because, he has paid for something which is half therapeutic, and probably, the conditions are going to relapse, and the guy, he or she is going to be, asked to go back to that therapy in one way or the other, which is again a much more painful process. And of course, it has all kinds of impact on your own reputation, the doctor's reputation, and all that stuff. And then obviously we know that, our patients are really good at going and doctor shopping. If they want, if they're not happy here, something must have gone wrong, therefore I'll go somewhere else, and things like that. So I think the experience really has been that if you can bring in data, and some of these data are, as I was saying, like, for example, you would see compliance running at standalone without patient support program. Say it would be a 3-month journey that you would see, and then you start seeing massive dropouts, versus compared to somebody on a patient support program, which would have 9 months there, on the program. So. But of course, you want to see even higher, that's would be our objective, would be to see, 2 years, 3 years, down the line, that's the kind of relationship that we can be building up. So data is going to be very, very critical.
And can I just add one very quick thing, that one of our smaller programs picked up that some doctors were underdosing patients, and we were able to prove the outcomes were a lot poorer than the proper dosing of patients. And we're able to influence that.
Yeah, and let me bring in Sanjeev into this conversation. Sanjeev, you talked a lot about the industry, but from a Janssen perspective, I think with all the vaccines and the TB portfolio you have, adherence and compliance has a very different meaning because it changes the whole healthcare fabric of the country, right? And on the other side, with the chronic portfolio you have, awareness building again has a very different connotation. So to me, the entire patient support and adherence has the whole continuum for Janssen for you in India. What's been your experience, and where do you think you are on the maturity curve and where you wanted to be with respect to both of these?
So, I would again urge you to take this in the context that we have to realize, I think there is a big realization now that the adherence to therapy is not just about how the patient looks at from what the doctor tells him or her. At the moment, when we talk about any adherence programs, we start talking about the diagram of patient at the center, correct? And I think you mentioned it, he mentioned it. I think we talk of patient at the center because the patient puts money on the table and there are everyone around it who says that what's my share out of it. Yeah? So, as we start thinking of adherence to therapy, we have to start thinking we are in the center. And there is this patient, humongous patient with an amphibious form around us. And then what are we doing for that amphibious form? And as we turn that reverse way, we start thinking about different means of adherence to therapy. And you mentioned about tuberculosis. Let's understand tuberculosis as a difficult disease, and you do a lot of work in tuberculosis also. That first of all, the treatment duration is months together. Multiple tablets to be taken. And then top of it, there is multi-drug resistance and then extreme drug resistance. And I'll give you some statistic. You talk about patient want to adhere to therapy. Multi-drug resistant patient over 2 years takes 14,000 tablets and injection every day. What motivation the patient has? And then we talk about adherence to therapy. We have to reflect back and understand that patients sometimes don't adhere to therapy because it is very painful. It is not very easy. And there are different circumstances under which we need to think of. So we have to start thinking, how can we apply thinking model to going from discovery, research, until how the patient gets better. And when we start looking at the whole continuum, we start delivering better adherence. For example, why can't there be a HIV-like situation where the patient took 28 tablets a day in 1995 and takes one triple combo a day today? Why can't it happen in tuberculosis? And then we start thinking of adherence in a different way. But we want to talk of adherence from the starting point of, okay, I have this and patient better adhere to. It doesn't happen that way. Second is motivation for the patient. Belief drives behavior. And why TB drugs get toxic is basically because there is no nutrition. And Dr. Ratna Devi can give you long lecture on how nutrition really makes impact on everybody. So, solve the nutrition problem, solve the right problems. Why are you solving the wrong problem? Support the patient on nutrition. So now you have solved one more issue. Second is, you tell the patient to take sputum or take tests at your own willingness and whenever you want to see the patient. Why can't the patient see the progression of regression of the disease, him or herself, and start feeling happy about it? Do we build a simple drawing board chart to say that every month how the patient is doing? Build that motivation. So adherence to therapy has to be also centered around a belief behavior model of the patient. How can we build that? And that is what we are working on. Whether it is chronic care, whether it is biologics, whether it is TB, whether it is any other disease, we have to start thinking that there are different elements to adherence to therapy, and it's not about taking 3 tablets a day. And start thinking what is right for the patient therapy. And I'll tell you, not related to Janssen, but I'll tell you another example is, I remember in past time, a very senior court, a senior judge. These days it's difficult to talk about judges, but let me say that, So this person was starting to undergo dialysis. And now, we are talking to him, okay, you do this, you do this. And then for a moment, the judge said, okay, what are the options that I have? I want to still go to my court. And then we discuss with him peritoneal dialysis, we discuss with him hemodialysis, and we discuss what he can do in kidney transplant. And then he says, okay, look, let me bridge it this way. For next 2 years, I want to continue with dialysis because then I will do my kidney transplant. But then, peritoneal dialysis suits me more if you create a condition in the court for me where I can take my peritoneal dialysis whenever required. And once that was done and a nurse was assigned, the judge went on to become something very big. Again, I want to be cautious of trying to say something because you can make out then. So it's how things happen. So adherence to therapy has to be thought from the point of view of what the patient wants and not what, a chart being drawn that take 3 tablets a day, 4 injections every alternate month is not adherence to therapy. It has to be dictated by what the patient needs, and it has to be dictated how the patient sees progression and sees development of having taken control of the disease and managing his or her condition. Once that is done, we missed the psychology part of the story, but once that is also done, there will be better adherence to therapy. And this is what the models we are trying to build now at Janssen, that look, can we really incorporate everything? And we have the strength of Johnson & Johnson entire organization because we can think in many different ways. We can think in medtech ways, we can think as a consumer what the patient thinks. We have ability because we have people around us who can think that way and therefore build a much better ecosystem for the patient to deliver adherence.
So well put, Sanjeev. And let me bring Dr. Ratna in here. Dr. Ratna, you worked at the grassroots level, you worked with large pools of patients, you worked with the government. You've had an amused expression while you watched this conversation going on. What's your take on all this? And where do you think as an industry, because as an industry today we are faced with many, many challenges. One of the biggest challenge is that of a complete breakdown of trust across all the levels and stakeholders. And the program that we are talking about, at the core of that program is trust and not anything else, right? So what's really your take on this?
Okay, I'll just pick up from one of the opening remarks that Sanjeev made, and it's a very profound statement which said, to be able to manage the current disease burden of the country, we need to grow by 3.5 to 4% of GDP, with a caveat that the population will not grow anymore. So at the rates at which the populations are growing, we probably will never be able to reach our targets. Now, having said this, juxtapose it with the current healthcare system where we don't have enough hospitals, we don't have enough human resources, and we definitely do not have the finances, even if we had everything else in place. So where is the solution? And that is what worries me in most discussions where everybody talks about treatment in hospitals. So instead of getting a hospital into the patient's home, I think what we should be talking about is getting the patient out of the hospital. Let's not talk about medicalization of healthcare. Healthcare is much beyond just the medicines and the hospitals and the doctors and the nurses and the systems. And let me ask a question. How many diabetics or people on hypertension ever go to a doctor for a refill of their prescription? For years, people manage their disease without complications if they have the other support systems, meaning lifestyle and everything else, and they do a good job. They only go to the hospital when they have a problem. I'm not saying that's the best model, and that there should be frequent, medical checkups so that they really don't progress to a complicated situation where they have to go to a hospital. But coming from some of the successes, and again, he mentioned HIV. When they initially started the program, it was just a 1-month prescription that was given to the patients. And every time the prescription was about to be over, just a week short of it, the patient had to come back to an ART center to receive their prescription. Until somebody said that if this person is actually managing his CD4 count and all other medical tests and is not really sick, why don't we give a 3-month prescription or a 6-month prescription? And the community then, and that is where the expert patients come, actually manage the condition so that they are able to recognize if the patient is not moving well, or if there are complications, or if the patient needs to actually go to a hospital. So I would suggest that instead of working through the traditional system of the doctor, and the whole system of the nursing and everything managing the patients, let the patients to get together to manage their disease conditions. And in many not difficult situations, patient groups can actually manage it very well with the right kind of support from the healthcare system. And that is one area I think where the pharma industry can work with. Strengthen the patient groups so that they're able to manage their disease conditions better with the right kind of communication tools, with the right kind of patient skilling programs. A lot of work that nurses do, which does not need the technical part of it, can actually be done at home by patients. And there are more and more point of care diagnostics coming, where the patient can actually diagnose himself. However, most people do not do it because they are scared, or they don't know how to interpret the results, or they have these half-baked misconceptions that what if I read the result wrong and I don't know what to do about it. So there's a huge opportunity there where people, if they can be diagnosed early through the right skilling programs, and then facilitated to go to a healthcare provider who confirms the diagnosis, and then the treatment is started, can actually go on treatment without any complications through peer support. And that's an excellent area where patient groups can actually shake hands with the pharma industry to be able to manage compliance, adherence, everything else that we were talking about, without really investing too much. Because that's not a very big investment where you have to have a infrastructure set up. It's just about skilling people and then supporting the right kind of patient groups. The second one that I was wanting to talk about is, we talked about the management, even the prevention part of it, and like you said, the nutrition part of it. Healthcare is not just about popping a pill. It's also about managing yourself, managing your workplace, managing your family, so many other things. And I think there's a huge opportunity here to shake hands with like-minded partners. How do we all join hands together so that there's a nutrition provider who is also there as part of your adherence and compliance program. There's also a livelihood mission that's joining hands with you so that this person is able to make a livelihood and is able to work together. And here again, I think the patient groups can act as the bridge, because that is where everybody will connect together without having any biases. Because all patients who are there in the patient groups have the same motive, the same objective, and the same desirable outcomes that they want for the condition, not only to be treated, but to also be able to live a happy life. I think that's where I would like to close.
That's fantastic. I know we've got about 9 minutes left, but I want to share two small snippets with you. They are both personal stories of mine before I open it up to the audience, and it's been a fantastic panel discussion. See, one is, my father, who's now 73, has been a diabetic for almost 40 years. He was diagnosed with diabetes at the age of 33. And to me, when I look at patient support, I think we need to change it to calling it patient empowerment. Because over the last 1 year, when I became more aware of how you need to manage a condition, he was supported by technology, he was supported by a GP, he was supported with much more information, and we could bring down his insulin from almost 25, 26 units to 6 units a day. And he's done it all by himself, but it's all about a lot more information, the right hand-holding, the right nutrition, and feeling that he's empowered, right? I think the second thing is, when I was 40, and because my whole family has been a diabetic, I realized that I have to take my own health in my own hands, right? And I knocked off almost 16 kilos. I went into an exercise regime because it's not about resigning to the fact that you will get the disease because you have to get it. It's also about figuring out how you can take a lot more ownership of health, because it's one of the variables you manage along with many others, and sometimes we miss that fact. And the last point, Dr. Ratna, you put it so well. I think it's not the bastion of a provider or a pharma company or a technology player. I think it's about how you bring all of it together, and somebody has to play that role, pretty much. And it's not just about popping a pill, Sanjeev. So with that, thank you so much for all the key points. We've got about 5 minutes left, and would invite questions from the audience. Please do introduce yourselves, and please keep your questions crisp. if possible. Thank you.
Hi, good morning.
Good morning.
It was excellent discussion, and my name is Jagmohan Singh Rishi. I am from Wokhart, the digital strategy team. I have one question to Dr. Gareth. For the program which you have mentioned, what are the critical success factors for the program which you have launched in London or in UK connectivity? Sorry, what are the critical success factors for the success of the program which you have done in UK?
Yes, I do understand the question. Thank you. Well, going back to one of my previous points, certainly working with pharma and agreeing joint objectives, then critical success factors come from providing the evidence of the value and the outcomes, the clinical outcomes. Now, patient comments on the care package or the patient support program that you provide are very important. Of course, most of them are subjective, but nevertheless very important. But I think universally, I was just thinking back to one of the best plaudits we ever had from a patient, because we always ask patients how, their thoughts on the program that we provide. But one particular lady, this was an oncology patient, but she said, "Thank you for treating me like a person and not a patient." Now, this is recognizing the fact that you're not just an oncology patient, you're not just a diabetes patient, because people have lots of other needs. And if we recognize those, you can make a huge difference. Going back to many points that the panelists have made, you're not just a diabetes patient, you are a person with lots of other needs that other players can bring together to the party. But key success factors, clearly in the clinical world, you have to prove safety, you have to prove health outcomes, and that requires a good technology platform and the data to demonstrate to all the players in the system. So going back to one of the comments, demonstrating to the patient that the outcomes are excellent and as good, if not better, than elsewhere through hospital or anywhere else. To prove to the doctor, the prescribing clinician, who's still involved in this, he might be several hundred miles away, but to prove to the doctor that this package that everybody's signed up to is working, the patient is happy, it's cost effective, patient's taking the treatment properly. And to the pharma company who's very much involved, clearly the data has to be anonymized, but this data is a gold mine to pharma because they have to understand they spent millions and millions on clinical trials, and then they have to understand what happens in the real world. So, this is what we are trying to do in India with the many challenges that we've been discussing. But early days in India, but I think the market as a whole has made a good start, and we're trying to do the right things.
Thank you, Gareth. Thank you, Jagmohan. Yes, the gentleman.
Yeah, hi. My name is Ankur. I'm from Johnson & Johnson Medical. I have a question from anyone who can take it on the panel. So when we talk about patient at the center, and we're looking at different modalities for patients and alternate ways in which patients can be treated, the traditional way of meeting the doctor will always continue. The doctors are currently very uncomfortable with the patient being very empowered. With digital media, etc. coming up, when a patient is unwell, the first thing that he will do, he will look up the internet, understand his disease condition, are other people going through it. There are many WhatsApp groups that are there today which kind of give you some data. Some are authentic, some are not. But somewhere when the patient wants to know more about his condition from the doctors are very uncomfortable answering those questions. They call them Dr. Google and things like that, and they're very uncomfortable. So my question is, how comfortable are the doctors today? Are they ready for this change in environment that is happening? I mean, while the patients are being empowered and things like that, are the doctors really comfortable with this change, or are they ready for this change? Anyone can take it on the panel.
To answer your question in short, no, they are not comfortable. But that's not true across all specialities. In some areas where patient groups have become strong, they are actually working very well together. And I've worked for hemophilia for a very long time. And there, the hematologists are actually a strong support for the patients to, inform the patients what new therapies are coming and how they can be brought into the country. And the patient groups are actually the ones that talk to the government saying, we want these therapies. However, that's not true for all disease conditions. It's where the patient groups have become more stronger, more mature, and they have a one-on-one conversation as equal partners with their care providers. This change is happening. So hopefully in other areas and other disease conditions also it will happen over a period of time.
So maybe just to add to that, I think this is where I think we need to understand that, you see, the realities of the marketplace are very clear. We have said that the patient doctor ratio, that's possibly going to continue in terms of the crunch that we see over there. The question comes in is that, then what are we doing as organizations, and of course with the support of the doctors, how do we empower and train the nursing staff, the counselors over there, so that the doctor in turn, without spending a little bit of time, but quickly passes the patient on to that particular nursing staff, etc. And I think this is where we as organizations also need to think of the system as a very holistic system. We are right now, we are so much more focused on just educating the doctor in one way or the other, but we really need to think through in terms of that if we are launching a product or we have an ongoing product program, how do we really approach and what informations do we need to empower each of the different people in the spectrum of the healthcare, who are providing that healthcare, and that group to me is of very, very critical importance. I think I'm sure all of us in some way or the other, as organizations, we do allocate monies towards making sure that we have empowering programs. We also know the kind of resource crunches that there are with these. Who's there to educate these nurses? Looking at their upgradation programs and treating them with disease and how best they can look at it. So I think we need to take that also very, very seriously.
Just one small comment is that, rather two comments. One, I think the model of patient going to the doctor, which you say will remain, you will see how quickly it will go away, wither away in many parts. So don't consider that this is going to sustain. Second is the operative part of the word empowered patient is power. And that power shift is what the doctor is uncomfortable with, and nothing else. That discomfort comes from a powerful patient, or therefore when patient groups come together, the power shifts. And that's where doctors tend to behave very differently. So we need better patient group activation, which doesn't indulge in things which are not required. For example, it's not about driving, it's just not about driving costs down, it's about driving better healthcare. And if that equation is set right, an empowered patient is a powerful patient.
Ankur, you should see this two websites I would suggest. One is a company called Medivizor.com, Medivizor, right? It's an Israeli company, but it'll show you how some of the chronic patients are coming together and actually creating very enriched discussion, dialogue, and content, which other stakeholders are looking to. The other is a company from Garrett's own country, Health Unlocked, right? Which is again one of the largest patient communities, which started from rare diseases but has now taken on many, many other dimensions. Yeah. So you want to say something?
I just wanted to add something. I know we are out of time, but quickly, we always talk about patients, doctors without thinking of the bigger, larger environment. And we do know for a fact, even in our daily lives, that many of us miss medicines because the environment at workplace is just not there. And whether it's organized or unorganized sector, it's the same for both. And that is another reason why a lot of compliance issues or adherence issues come. So if there is some method of helping these patient organizations move the policy platform for a workplace policy which says or enables patients to have that time to be able to take meals at the right time so that they can have medicines, that's a huge shift. And I think that's something that all of us can agree to work on.
So thank you. I think we are done with time. Fantastic panel. Thank you so much to all of you. Thank you for being a fantastic audience. And we'll close the session.